I'm going to tell you how DBT was developed. I mean, it is an interesting story, but that's not the point of telling you. It actually, in hearing this story for a few minutes, I think you get, you sort of hear what is in this treatment, because it was built kind of one layer at a time. Marsha Linehan, in the 1970s, she got her psychology training in New York and on Long Island at New York University, Stony Brook at New York. And it was a hotbed of cognitive behavioral therapists. And that's what she was interested in. Now, many of you may know, but you may not know. She came out last year, 30 years after putting this treatment into the literature and building on it, and told her own story, that she went through a hellish childhood in a perfectly nice family that didn't understand her and didn't get it. She was different than everyone else in her family. She has siblings, I know some of them, who are really accomplished, really good people, work really hard, are very recognized. Her parents, it was a very... And Marsha, she was brilliant, but she was also outspoken, and she was sensitive, and she was emotional, and she gave people a hard time, and it didn't fit very well in her family structure and their system. And she just went through childhood having a lot of struggles. By the time she was 19, they decided to send her to a hospital in Connecticut, where she was for a year and a half. And she spent a good part of that year and a half in the sort of lowest functioning ward, the highest security ward, and a lot of that time in isolation in the security room. And when she'd get out, she was just hell on wheels, and she would be wanting to hurt herself, wanting to kill herself, giving people a hard time. It was just very emotional still. It was like continued to go on. And there was a certain moment in her story where she was in one of those security rooms, and she said to herself, kind of like a vow for her life, if I ever make it out of here, out of hell, I'm going to go back in and get all the rest of them, meaning everyone else who suffers like me. God damn it, this is terrible. They did not know what to do with her there. And actually, just a good lesson for all of us is the thing that helped her get through those 18 months was not that they knew what to do with her, was that these two doctors, one psychologist, one psychiatrist, admitted that they didn't know what to do with her. And they did it in a kind way. Marsha, I just want to tell you, we are working our butts off here to try to help you. And we know we're not hitting the spot. And we know it's not working. And we're so sorry. We wish we knew exactly what to do. We hope we'll figure it out. But in the meantime, we just want you to know this is not your fault. However this came about, it is what it is. And we're going to stick by you. She said this kind of kindness in the face of not knowing what to do was actually fabulous treatment when you look at what a lot of people get. So that she talked about that. She did get out. She did have some other experiences. She was back in the hospital again. She had a spiritual experience. She decided to go to grad school to learn cognitive behavioral therapy to treat people with suicidal behavior. And ever since, this has been her mission. She's now in her 70s. She's still on the same path. Okay, so going back to her story, she's a cognitive behavioral student at Stony Brook in New York. She learns cognitive behavioral therapy. She starts applying it to the suicidal population, and she starts developing DBT. The first layer of developing it was to take standard, straightforward cognitive behavioral therapy. What does that mean? Skills training, teaching people skills. It means addressing people's thoughts, because there's problematic thoughts that get you in trouble. That's cognitive therapy. It means doing exposure treatment with people who are trying to run away from things and avoid things so that they can desensitize themselves to sort of normal cues in the world rather than always running away or hurting themselves. Right? That's standard cognitive behavioral therapy. It means paying attention to reinforcement and shaping and extinction and these kind of principles of how you change behavior. Cognitive behavioral therapy. She starts doing that straight out of the book, like used for panic disorder or OCD or PTSD, and starts applying it to this population. And lo and behold, it didn't work. Clients felt pushed by her. They felt invalidated. They felt that she didn't understand their suffering. She was giving them Band-Aids, telling them what to do. They were pretty pissed off about it sometimes. She'd say, well, you know, this week, how about trying this skill? When you get really suicidal, you really want to die, here's what I want you to do. Go in your kitchen. Get a pot of tea. Heat up the water. Get your tea ready. Focus mindfully and totally, as if there's nothing else in the world, on slowly and gently making a cup of tea. And then sit in your nicest place in your house and just sip the tea and just let yourself notice the taste of the tea. Patient blows up. You kidding me, lady? Have you ever had a life? I mean, do you know that I can barely get through every day? I want to kill myself. I may be dead tomorrow, and you want me to have a cup of tea? This is treatment? You know, so she would get that back at her in various forms, and she realized she's going to have to change this. And she starts changing, until a few months to maybe a year later, it's starting to look like a little bit different treatment. It still is cognitive behavioral therapy at its core. She has never given up the idea that that is the bitter pill that has to be swallowed to change behavior. That is scientifically understood, researched to treat people with CBT. But you can't just do it straight with these patients because they've been through too much hell, too much suffering, and they're sensitive and they're reactive and all these things. So you have to add in validation. So the second layer of the treatment is she starts validating them more. What might that look like? That might look like saying, hey, I know you're still suicidal. And I know this week you're probably going to face more of it. So I have an idea for things you might do, but I want to tell you it's going to sound stupid. I want to tell you in advance. This may sound stupid. It may not even be worth telling you because actually I don't want you to just feel worse because it's a very concrete suggestion and you're suffering at such a deep level. You know what I mean? Yes, I know what you mean. I am suffering at a deep level and there's no way I can get out of it. Okay, so are you willing to just hear something about a suggestion? Now, she might lead in and do that. What that is doing CBT with a layer of validation around it. It's anticipating her reactions. It's giving credibility to her dislike of a skill, and yet it's pushing the skill itself. It's like saying to your kid, no, I won't take my antibiotic. But honey, you have to take your antibiotic. I won't take my antibiotic. It tastes terrible. I know, but we'll mix it in applesauce. The applesauce is the validation. The medicine is CBT. She starts doing this. Things are better, but it's not good enough. Because why? These people have been through such weird, sometimes, experiences in their lives and in their environments and in their nervous systems that still doesn't quite do it. And the reason it doesn't do it is a couple things. One is if you push the patient with cognitive behavioral therapy and say, change, 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 the patient's reaction is, screw you. I've changed enough. Everybody tells me to change. I've spent my life hearing people saying I should change. And it makes the person more dysregulated. So then you say, oh, no, no, no. Wait a minute. I'm sorry. Maybe you weren't ready for that. Actually, am I pushing you too hard? Yes, you are. Okay, you know, I just want to tell you, I get it. I get it. It's very hard to get out of this. And if you stay with that for 30 seconds, the patient might say, so now you're agreeing with me that there's hopeless. Well, no, I'm actually not. I actually think there are some solutions, but I think you're really in a terrible situation. It's really painful, isn't it? You're like in hell. You're deep in a well. Yes, I am. And you don't have anything for that? Well, actually, I do. Push, push, push. Why are you pushing me? So in other words, it's really like a delicate balance. How do you push people to change and they feel invalidated, and then you just sit with them and listen to them and empathize, and they feel hopeless? This was the dilemma that came out of that next layer. So then she starts building another layer. She starts trying things out. It's very interesting. She turned to family therapists, systemic family therapists, Carl Whitaker, Jay Haley, all kinds of things like that. She turned to systemic thinking, paradoxical therapy. She started figuring out, what else can I do to make this work? And the basic idea that came out of that ultimately was dialectics. At its core, this version of dialectics means that you find a way to push the patient, push, 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 and at the same time, hold, hold, hold. Validate, validate, push, push, validate, push. And sometimes at the same moment, you're doing both. in all kinds of creative ways. It includes some improvisation. We'll get to dialectical strategies tomorrow, because that's a part of the treatment people often don't feel they quite understand, but I'm going to get you to understand it tomorrow. But the basic idea of it is that you really have to attend to both sides of this equation, that the person needs deep, constant validation about their experience. You saw some of that in the little videotape when I said, you know, of course you would feel that way, or who wouldn't? Yes, I would have the same thoughts that you do if I was in your position. No doubt about it. So would other people. That's right. Then she says, well, at least you understand. I thought you were going to be mad at me. So there is the validation, but if you just validate it's not DBT, there has to be a real pushy quality. It's like tough love. Okay? So there's dialectics in order to break down the impasses, which are conflicts, which are blockades. And then the last thing is she realized, I'm having my therapists do all this, and it wears us out. And so she added a layer on that she called practice. Practice really means take the valuable lessons of this treatment and turn it on the therapist. So the therapist also gets good at regulating emotions in the face of distress, because the therapist is going to face distress. You can't become a firefighter without facing fire. And you can't treat borderline personality disorder without facing emotional dysregulation right in front of you and getting inside you. So she feels like the lessons of this treatment are also brought to bear on the therapist as a way to settle down and use the treatment, and that's called practice. And there's a lot of elements to each of these, but this gives you a kind of overview of the treatment, which I then, I think in the next slide. So there are 5 essential ingredients of DBT that follow straight from that. If you really understand this, you're already ahead of most of the world on understanding DBT, let me tell you, because people lose the forest for the trees. They get into doing this and this and this because there's a lot of things to do. This is the big picture. You really got to get it.